Welcome to our Grand Round series. Our Greenberg bladder cancer team are grateful you're here. First, a couple of updates. This is our last session of this semester, so please review your emails. The new calendar for 2025 will be out shortly. For updated information about the Institute, be sure to simply Google Greenberg Bladder Cancer Institute. As you know, we are always expanding our educational offerings, including our growing collection of programming led by Drs. Armin Smith and Jeannie Hoffman-Sensis, and program team members Pamela Getz, Samantha Rockler, and Stephanie Cooper Greenberg, specifically tailored around the experiences of women with bladder cancer. See our website for the next virtual women's group. Additionally, we have been working with our clinical providers to assure that our GBCI front door for care is easy to access. We have two email addresses, bladdercancer@jhmi.edu, and a more specific email for upper tract urothelial cancer patients, utuc@jhmi.edu. Again, all of this information and more is up on our site, and if we can help you directly, we are only an email away at bladdercancer@jhmi.edu. I'm incredibly grateful to all of you for joining us today for our conversation. I wish I had asked that. I hope you will allow me the chance to provide brief introductions for today's presenters. Lillie Shockney has dedicated her life to helping cancer patients and their families, both here at Johns Hopkins and across the world. At Hopkins, she served as the administrative director of the Breast Center from 1997 to November 2018, and as director of cancer survivorship programs from 2011 to November 2018, at which time she retired from her hospital leadership roles. She continues to serve on the faculty in the Johns Hopkins University School of Medicine, and also as the co-developer of WorkStride, Managing Cancer at Work, an employee benefit developed for Hopkins employees that is now being utilized by business and corporations nationally. A two-time breast cancer survivor, Lillie has worked tirelessly to improve care for breast cancer patients around the world. She's a registered nurse with a Bachelor of Science degree in Healthcare Administration from St. Joseph's College and a Master's in Administrative Science from Johns Hopkins University. She has worked at Johns Hopkins since 1983. She is also certified as a breast imaging and breast cancer patient navigator. Lillie is a published author and nationally recognized public speaker on the subject of breast cancer, having written 16 books and more than 300 articles on the subject. She serves on the medical advisory boards of several national breast cancer organizations and is the co-founder and vice president of a national nonprofit organization called Mothers Supporting Daughters with Breast Cancer. Lillie is also editor-in-chief of a new peer-reviewed medicine journal called the Journal of Oncology Navigation and Survivorship, which launched in the spring of 2011. She's the co-founder and director of the Academy of Oncology Nurse Navigators, a national organization that provides a network for all professionals involved and interested in patient navigation and survivorship care services to better manage the complexities of the cancer care treatment continuum for their patients. We are thrilled to have Lillie join us here today. We are also incredibly grateful to Stephanie Cooper Greenberg for joining us today to lead this important conversation with Lillie. As co-founder of our institute, along with her husband Erwin, Stephanie is a tireless advocate for bladder cancer patients and their families. In addition to her important work in bladder cancer, Stephanie serves Johns Hopkins on several boards, including the Children's Center and the Center for Innovative Medicine. Stephanie also serves on the Maryland State Council on Cancer Control and the National Clinical Trial Network's Genitourinary Cancer Steering Committee Task Force. A warm welcome to you both, and thank you very much for joining us today. Lillie and Stephanie have agreed to speak for about 30 minutes, and then we'll transition to a group discussion with all of you. I would ask for folks to please submit questions via the chats feature, and after the opening conversation, we'll have ample time for group discussion.
Thank you so much for having me today. It's a privilege to join you. I am coming up on 42 years at Johns Hopkins in February. And the number of books that I've completed and that have been published has now reached number 31. Number 31 happened 2 weeks ago. So I am always busy with my literary work. I'm going to see if I have sense enough to pull up my slides. So please bear with me here for a second. Well, it's being a little contrary here. So it's not letting me go to full screen. There we go. Whoops. Golly day, I went through that a little bit too quick. So my objectives today is for you to understand the rationale of beginning your cancer survivorship at the moment that you found out that you had cancer. Learn the most common barriers to cancer care and whether or not you have any. Recognize the dramatic changes in the last decade have become regarding the goals of cancer treatment for you, because no longer are we just looking at you surviving. We want you surviving with good quality of life. Learn the value of starting survivorship care at that moment of diagnosis and its impact on quality of life for you, that we want to preserve your milestones as well as maintain your life goals. And become informed about the causes of the shortage of oncology specialists today and its impact on cancer care nationally, and learn the barriers to transitioning a cancer survivor back to their community providers. Understand the concept of a shared care model. That means your PCP, your primary care physician, remaining connected to you throughout your cancer treatment and not it being a pass off and just have oncology take care of you and then pass you back. Learn how to help yourself create your new normal. A lot of people will say, I'm still trying to find my new normal. Well, it isn't under a rock. It's something that you need to be creative and to think about. We'll talk more about that too. And learn the negative impact that lingering side effects have on a cancer survivor's quality of life when they actually go unaddressed, and they should never be unaddressed for you. Understand the enabling behavior that happens between oncology specialists and cancer patients, and learn the essential components of a survivorship life plan and who is responsible for what. So if you weren't a cancer patient at Johns Hopkins, I would be saying this to you. Get a second opinion at a Center of Excellence or NCI designated cancer center, which Johns Hopkins is. Inquire how many cancer patients with a specific type of cancer that you have has this doctor or this team of oncology specialists taken care of. Because you don't want to be, number 7. You want to be number 7,000, quite frankly. What, if any, clinical trials might be that you might be a candidate for? What is the survival rate by stage of disease? And how does that compare to the national SEER data? So you want to know specifically for that oncology team and how that compares to national. I intend to be directly involved in my care and decision-making about my treatment. Are you good with that? See what reaction you get. Who are the other members of my treatment team and what is their role in my care? And is there one person among the team members that will be my point person, my go-to person for my questions and help? Inform the oncology team if you have any of these barriers, because many patients do. Financial and economic barriers. You might end up surprised to know how much your copays and deductibles are. Language and cultural barriers. In certain countries, for example, women may not be allowed to be told what kind of cancer they have or even that they have cancer. So that could be a little bit challenging in taking care of someone if only the men in the family can be informed. Communication. If we don't understand what the education level is of our patients, we may be talking way above their head, which is wrong. We also don't want to use too much medical ease language either. We want to talk in a way that it can be understood by anyone. The healthcare system may have some barriers, being able to access care easily. If you're put on hold forever, or they say they'll call you back and they haven't, and you need to get in to get particularly that first consultation under your belt. Transportation is the #1 barrier in the United States for cancer patients. A lot of people may take a bus to work, but that bus doesn't go to the cancer center. Bias based on culture, race, and age is an issue, and just plain old fear. Some people believe if I have cancer, I'm probably going to die anyway, so should I even pursue treatment? That is still an issue, and it has been for decades. As for resources for undoing or preventing barriers, there are a lot of local resources. For example, patient advocacy organizations that will provide food to you and your family, childcare while you have your appointments, especially for the time you're having chemotherapy, and free taxi vouchers for taxi rides. Regional resources also can be for transportation, food, or even financial support if you're not able to pay your gas and electric bills while you're receiving your treatment. And then national resources, for example, drug discounted programs, pay patients' utility bills as well as their rent. Now, potential benefits that can measure the effectiveness of a navigation program, I also want you to be aware of. It results in improved coordination of high quality care, enhanced access to services for all patients, removal of those barriers that I just described to you, more efficient delivery of care so you don't drop through the cracks or there's long delays between one phase of treatment to the next, improved clinical outcomes for you, improved sharing of resources, enhanced relationships with the community so that those resources are accessed for you, and you get to know what's really right in your own neighborhood. Increased patient satisfaction, or what I call the patient experience, and increase in referrals of new patients to the system, because you're going to tell other people what you experienced at Johns Hopkins. If you had a good experience, you're going to tell 1 or 2 people. If you had a bad experience, you're going to tell between 10 and 14 people. Your first interview with your oncology provider, or it might be that multidisciplinary team, this is how I want you to approach it, to let them know you are more than just your pathology. You are more than your diagnosis. You're more than your stage of disease and the prognostic factors that are associated with it. If you are not asked the questions below, I want you to go ahead and give the answers to these questions anyway. Be assertive, and when you have to, be aggressive. Be your own advocate whenever you need to be. So questions to ask are, how much do you know about your cancer? That's something I would be asking you. I work in the breast cancer arena, and most particularly with metastatic breast cancer patients, those with stage 4. And it's not unusual for me to have newly diagnosed patients say, well, I have breast cancer, lung cancer, and bone cancer. And I go, oh, no, actually, you have metastatic breast cancer that has spread to your lungs and to your bones. Oh, I've been looking up lung cancer on the internet. Well, stop. I'll give you the right URLs for you to access credible information, and it's all going to focus on metastatic breast cancer. How much do you want to know about your cancer? Not everybody wants to know everything. Some people want what I call just-in-time information. Just tell me what I need to know right now to make decisions about that first phase of treatment. And then when we're ready, I'll tell you when I want to have more information. Other people want to know everything soup to nuts. What are you right now hoping for? Right now, today? Think about that. What are you hoping for? What are you most worried about currently? That's a pretty heavy question. Very important to share that with your team. Tell me 3 things that bring you joy. And those are things that tell us a lot about your quality of life and a lot about you personally. Where do you see yourself in 1 year, in 5 years, or in 10 years from now? And answers may change over time. They probably will. So let your doctor know at each of those visits that you have if you've had a change and maybe you're hoping for something different, or you even want more information about bladder cancer than what you thought you did when you last saw the doctor. Tell your doctors to always be honest with you and that you will always do the same with them. That is a problem that is a national problem, that people think, I don't think I better tell my doctor that I'm not taking my medication as prescribed. If he asks me if I'm taking my medication, I'll say yes, because I am, but I'm taking it every other day, so maybe I can have half the side effects. Well, we've never done research studies on taking it every other day, so it may not be doing a daggone thing for you. The importance of honesty and saying, I'm having trouble taking this medicine because of these side effects. What can you do to help me? I'm really big on shared decision making. I don't want things done to you. I want things done with you. So don't have treatment that is going to be done to you. Have it done with you. And that means you need to be able to participate in shared decision making about the treatments that you're going to be having. State what you want to be empowered with information so that you can understand, so that you can actively and confidently participate in the decision being made jointly regarding your treatment plan. Treatment for treatment's sake, I will tell you, is bad care. Make sure you understand what a new line of treatment may do for you and weigh the risks and benefits each time that decision making has to take place. So there may be 12 treatment options. You may say, well, if the first one doesn't work, I'll go on to the second one, to the third, until I've gone all the way to number 12. You may find when you hit number 6, you are really, really sick, and the benefits are getting smaller and smaller. You only may reap a 5% benefit from that treatment number 6. You want to step back and think about this. Do I want to do this, or do I want to take a different path? Survivorship must start at the moment of diagnoses. All too often, survivorship is looked at a phase of care that happens after you have finished your active treatment, your surgery, your chemotherapy, immunotherapy, your radiation. Now we'll talk about survivorship. And I say, no, we're going to talk about it right at the time of your diagnoses. Oftentimes it is a nurse navigator, but it may be another member of the team that will interview the patient about what her life goals are before she was diagnosed. She had a life before her diagnosis. We want to learn about that. We want to know, where does she see herself in the future? Does she want to still have children? Maybe she has one, she wants to expand her family down the road, or she doesn't have any yet, but she was hoping to have a child maybe 4 or 5 years from now. Then we probably need to get her into fertility preservation if her stage of disease is stage 1, 2, or 3. Is studying to become a concert pianist, though works currently as a bank teller. That was the situation. I had a patient who had worked at M&T Bank downtown for 8 years. And I said, do you see yourself as president of the bank one day? And she said, oh, no, I work at the bank because the hours are perfect for me for what my career plan is, because I plan to be a concert pianist. And I was like, oh, gracious, we were going to be starting her for her first treatment with chemotherapy and then doing surgery second. And I knew the drug of choice we would be giving her caused peripheral neuropathy, numbness, tickling, and pain in her fingers and toes. If we had given her that drug, she probably wasn't going to turn out to be a concert pianist, because oftentimes we find that the peripheral neuropathy never totally goes away. And she may have said to people, you know, cancer caused me to forfeit my career goals. And I'd say, no, we caused you to forfeit your career goals because we didn't ask you these kinds of questions. Because we don't want you to give cancer any more than what is needed to get rid of it or get it into control. Don't let it take away any more of you than absolutely necessary. It doesn't deserve it. She's up for a promotion at work. Can we dovetail a work schedule with a treatment plan? Most of the time we can. Instead of getting radiation at 1 p.m., let's have her get her appointment at 7 a.m. Before work, or at 5:30 p.m. after work. For my patients, I'll say, you know, you're going to be having a lumpectomy done. Friday is lumpectomy day in ambulatory surgery at Johns Hopkins. We run 3 rooms at once. So let's have you have your surgery at that time on that day. And having a desk job, we can have you back at work physically or certainly virtually on Monday morning. And that usually works out quite well. Most important role of an oncology navigator is to serve as a patient advocate. Be the patient's voice at the tumor board meetings, at those multidisciplinary consult meetings. Tell the multidisciplinary team what the patient wants to do when the patient is hesitant to bring it up herself. Examples for metastatic patients is the patient wants to stop treatment and enroll in hospice, but is afraid that the team will be angry with her, or that the treatment team will say, "Oh, no, 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 don't give up yet." It isn't about giving up. When I transition a patient to hospice, I've worked with her to develop criteria as to how does she want to be feeling, how well or not so well are the treatments working. And hospice is about giving the patient control back over the remainder of her life. It is far, far, far from giving up. And as I said earlier, treatment for treatment's sake is actually bad care. She wants to have a lumpectomy so she can't feel the tumor in her breast every morning when she washes in the shower. Some people would say to that patient, well, that's not part of treatment that we do for stage 4 breast cancer patients. This is psychologically important for her. She's not believing it's going to make her live longer. She's saying, I don't want to feel this tumor every day. And I do. I just want it out of me so that I don't have to feel it anymore. So understanding the rationale from you as to why you want to do something in a certain way. Goals of treatment, historically, there was one goal: survival. There was no other goal. So if you lived through your treatment and survived it, you would be a success story in the eyes of the treatment team. But today, really our goal is survival with good quality of life is what we expect for our cancer patients. More patients are living with metastatic disease than ever before. I sometimes refer to them as forgotten survivors. The disease needs to be treated as a chronic illness, and in most cases today, it can be. So we see fewer and fewer patients who look like they're actively dying all the time. We see patients that are still at work. We see patients that are on the golf course. They may have metastatic disease, but we're able to treat it long term and have her live in harmony with it. We must ask you, what are your goals of care? And be in agreement with these goals whenever possible. Otherwise, we might not be singing from the same sheet music. Milestones and life goals. What milestones are coming up in the next 6 to 9 months while you're receiving your treatment? Maybe your son is graduating in 3 weeks. So don't schedule chemotherapy 2 days before that event, or you may not make it to his graduation, or you may be spending it in the bathroom when he walks across the stage. What life goals do you have? That 29-year-old that I mentioned to you earlier, who was the bank teller, but her life goal and career goal was to be a concert pianist, which she is. She also now has 2 children as well from having gone through fertility preservation before we started giving her chemotherapy. There are also life goals for those that do have advanced cancer. That doesn't mean that we can create a miracle and have them achieve them in 5 years or 10 years, but we may be able to help them develop an alternative way of fulfilling those life goals. Barriers to successful transition back to community providers. You've bonded with your oncology team who has saved your life. You may lack confidence in your PCP and knowing how to monitor, do surveillance, as well as address long-term side effects. Doctor may say, I have no idea how to take care of you with this. That's why I don't want you to unhitch from your PCP. I want this to be a shared care model so that oncology is communicating with the PCP is communicating with the oncology team. PCPs may lack confidence in themselves too regarding cancer survivorship, because that wasn't necessarily something that they learned in medical school. They're learning it today, but 15, 20 years ago? Nope, wasn't one of the things that they learned about. Oncologists express feelings of loss too. Social follow-up visits sprinkled in between newly diagnosed cancer patients is something that oncologists really do value. You become that patient who you're 7 years out, 8 years out. It is a social visit. You arrive there and say, oh, I've had a great year. I had another grandchild. How are things for you? I pray for you every night that things are going well. And thank you again for saving my life. And here's a box of chocolate chip cookies that I made for you. Doctors miss not just the patient, but the daggone chocolate chip cookies. And it is that social visit that feels so good. We're pulling those patients away, those long-term survivors, because there's more cancer patients to take care of and fewer oncologists that are choosing to specialize in patients with particular types of cancer. So that means we've been trying to put 10 pounds of salt in the 5-pound bag, and the doctors just can't do it anymore. So we scoop up those long-term follow-ups, have them go back to their PCP, or perhaps be in a nurse practitioner's clinic called a survivorship clinic, and we give more newly diagnosed patients to those oncologists. We can burn them out. We can cause compassion fatigue and reach the point of burnout where they say, I can't do this anymore. That's a huge mistake, bad, bad, bad mistake. So we need to find balance. And we also need to let you know right from the beginning when you were diagnosed and we first saw you, how long will we be following you? Patients with stage 1 should be followed for a shorter period of time than someone with stage 3, because the risk of someone with stage 1 getting recurrence is far less than someone with stage 3. And I think that just makes sense. PCPs opt to do staging workups also for medical legal reasons. So when we send you back to your PCP, you might say, I would love to get a full staging workup annually. And he'll say, okay, not because it's the right thing to do, because it isn't. It's because he's worried about medical legal issues. And we can always find something on a daggone scan, some ditzel or a pixel or whatever on there that then we have to track down. We may even have to do a biopsy on you, only to find out it was just artifact on the x-ray and that it was no problem at all. And we can scare 10 years of life out of you by doing that. Challenges regarding educating patients about possible late effects of treatment, resulting in increasing anxiety and fear. Some side effects may not show up for 5 years or 10 years. When they do show up, it's startling to everybody because it's a small percentage of patients that have them. But those that do have them, you could be in the 1%. That means 100% for you. So making sure that you are educated about these issues and when to call your oncologist and say, I need to come back. I now have this issue that has presented itself to me. PCP is not well educated yet how to manage these side effects. But as I say, that's something that we are now doing in medical school so that internal medicine doctors are better prepared. And survivors have greater difficulty reclaiming their lives and moving forward. We need to help you create your new normal. Your old normal is gone. This has been a life-altering experience. And as a result of that, you're going to look at life differently. You're probably not sweating the small stuff anymore. You may even want to change jobs and say, you know, I've always wanted to be a school teacher. I want to go back to college, finish getting that degree that I discontinued because I had a baby and had that life change. That's not odd to feel that way. I went through that myself. I specialized in malignant brain tumors, specifically glioblastomas, prior to being diagnosed with breast cancer. After my second diagnosis with breast cancer, so I had it in both of my breasts. I'm glad I only had 2 breasts. I thought, gee, I could keep doing this. I decided I want to specialize in breast cancer. I want to let people know I've walked the walk and talked the talk. Since then, I've also had uterine cancer. So I think I'm working my way down. I told my husband one day I might get toe cancer. If I do, then I'll know I'm done because I've gone down as far as I can get. The population is aging. I'm in the baby boomer club. It also clouds the symptoms that we might be experiencing because those side effects may be similar to rheumatoid arthritis, joint pain. We need to have the internal medicine doc and the oncologist talk and have a discussion and figure out how do we determine which this is so that we're treating the right problem. Is it due to just the aging process? I now have arthritis in several bones that I've broken. And first thing I thought about, though, was, do I have cancer again? And I had to think about it and talk to my oncologist, talk to my PCP, and they did the right tests on me to figure out, thank heavens, it was rheumatoid arthritis. Isn't it crazy to say, I'm so thrilled I have rheumatoid arthritis? Or is it a sign that the cancer's come back? And what do we need to do to get it into control? Improving quality of life during and after treatment is something we need to assume responsibility for you and do with you. Educating you regarding not accepting side effects as a given, what can be done to diminish these side effects or prevent these side effects. Why allow you or expect you to get deconditioned today, which will result in requiring you to get reconditioned later? We have programs at Johns Hopkins called cancer prehabilitation. I send my patients there when I know we're going to have to do an axillary node dissection of all the lymph nodes in their armpit. I want to prevent, if I possibly can, them from getting lymphedema of their arm. So let me get them in there and teach them some techniques that can prevent that rather than waiting for it to happen. And now we've got to fix the problem. Or range of motion being an issue as a result of taking out all of those lymph nodes, if they can only raise their arm part of the way. Let's get in there and show them what exercises we want them to do, start practicing them now, and start doing them 48 hours after their surgery. What were your life goals before you were diagnosed with cancer? And are these goals still what matter to you and need to be preserved for you during your treatment so that you don't sacrifice those very important things? Study on patient supportive care needs beyond educating about their cancer treatment. Using cancer-specific supportive care needs assessment, which is where that SCNS comes from. 30 to 50% of cancer survivors in a specific study that's footnoted at the bottom, almost 1,500, have unmet needs, mainly for psychosocial support and help coping with the fear of recurrence. Even I still have fear of recurrence, but it doesn't monopolize my thinking all day and every day. It can for some patients, though, and that's something we need to pay close attention to, because if it is, we're doing them a disservice by not getting them the psychological support that they need. 57% of these survivors were breast cancer patients. The rest fell into other solid organ tumor patients, very well like yourself. 30% reported more than 5 unmet needs related at baseline. And for 60% of these patients, they continue to have no improvement post-treatment. So most patients do not express these unmet needs for supportive care after treatment. So I want you to speak up and say, hey, I'm still having a problem with this, and I still need your help in addressing it. Take a look at this table. The most frequent unmet needs that got scored as moderate and severe. So it wasn't, I have a little bit of trouble, I got a whole lot of trouble with these. Fear about the cancer spreading, not surprising, 30%. Concerns about worries of those close to them. Uncertainty about their future. Worry that the results of treatment are beyond their control. Is this treatment going to work? Is it not going to work? How am I going to find out if it worked or not? Lack of energy and tiredness. For some people, they have chronic fatigue. Being informed about cancer that is under control or diminishing. Being informed about things you can do to help yourself to get better. General anxiety. not being able to do things that you used to do, and having one member of the staff with whom you can talk to about all aspects of your condition, your treatment, and your follow-up. This shows the percentage of patients not receiving care regarding their concerns based on a study of 2,300 patients. So 56% of these did not receive concern about their energy level. They were dealing with chronic fatigue. 83% had problem concentrating, also sometimes referred to as chemo brain. And even if you didn't have chemotherapy, you can still have chemo brain. Patients that have hormonal therapy will develop chemo brain, but also PTSD could cause chemo brain. Sexual dysfunction, 71%. Nobody wants to talk about sexual dysfunction. I am the Dr. Ruth in the breast center at Johns Hopkins. I talk about all of it. Neuropathy impacting 60% that are still dealing with neuropathy. 37% having pain. Oh my gosh, we don't want you to be having chronic pain after we finish your treatment. That's going to directly impact your quality of life in a major way. Dealing with urinary incontinence. That's a big number, 69%. With bladder, with prostate, with fecal incontinence also for prostate and for colorectal. Problems with their breathing, 47%. Cardiac complications, 32%. So it's like you thought you were done. No, you're not quite done because you have to deal with these other things that are anything but convenient. Cancer survivors, and how many more comorbidities do they usually have? This is looking at a higher age group, but certainly is important because I'm hoping everybody gets into their 70s, their 80s, hopefully even their 90s. And when we do, I'm now 71, we end up getting other things that happen to us, other things that are wrong with us. So for that age group 65 to 74, here we have one or more comorbidity happening in 94%. If you're 75 or older, nearly everybody's going to have one or more. And then look what percentage have three or more. And I'm in that group. I have more than three comorbidities. This breaks it down also by types of cancer, the top three cancers that they have studied by the Institute of Medicine. Issues also to consider: a survivor may resist seeing a physician extender in a survivorship clinic setting because they bonded with their oncologist. Enabling behavior. I had a patient call me. I hadn't heard from her for 8 years. And she had a very whiny voice, so I recognized her right away on the phone, unfortunately. And I said, "Oh, hello, Henrietta. How did you know it was me?" "Oh, it just was a good guess." Oh. She said, "I have a urinary tract infection. I want you to call me in a prescription for an antibiotic." And I said, "Well, wait a minute. Have you had a urine culture done somewhere?" "No." "How do you know you have a UTI?" "Because I had these symptoms 8 years ago, and my doctor called in a prescription." I said, "Well, you need to see your PCP, have urine culture done, and your PCP will order antibiotics for you if it's appropriate." So she hung up on me. She said, "You're not helping me." Bang. Thought, She called me back 20 minutes later and say, "I called my medical oncologist, and he was thrilled to hear from me. He said he missed me, and he called in a prescription for me to CVS Pharmacy." And then she hung up on me again. I called that medical oncologist. I said, "Why did you do that?" "Oh, it was so good to hear from her. So good to know how well she's doing. It wasn't any trouble for me to call it in." I said, "We don't know she has a urinary tract infection. We don't give antibiotics unless we know there is an infection." "That's true. That's true. Well, I'll try not to do that again." I'm like, enabling behavior. Survivor may not have a PCP. Maybe it was the PCP who misdiagnosed her for her cancer diagnoses. Then let's find her a PCP. We have 8 of them at Johns Hopkins that specialize in cancer survivors. How do you like that? Survivor may seek solutions for themselves to figure out the side effects. I have had patients, my own patients, with breast cancer going through menopausal symptoms because we take away their hormone replacement therapy. We put them on drugs that does hurl them into menopause, anti-estrogen drugs. And what do? They go to the GYN and say, I need a prescription for HRT again, and I'll be darned if the doctor doesn't give it to them. That is not the solution. We're working backwards. Some essential components of survivorship care: prevention of recurrent and new cancers and of other late effects, as I mentioned; surveillance, whether the cancer is spread, whether it's locally recurred or developing a secondary cancer; assessment of medical and psychosocial late effects too; and intervention for consequences of cancer and its treatment. There could be medical problems. I mentioned a couple to you earlier: lymphedema, sexual dysfunction, pain, fatigue, psychological distress for the survivors, but also for your family caregivers that were at your side through all of this. Employment issues can pop up. Health insurance, life insurance issues can pop up, and disability can occur. Coordination between specialists and primary care doctors to ensure that all of the survivors' healthcare needs are truly met. And I'm not a believer in a survivorship care plan. I want it to be a survivorship life plan, because your life goals need to be documented on that document and tracked to ensure that they are maintained and that you didn't have to sacrifice them to cancer. What additional life goals do you want to perhaps add to the life goals that you already have? Some might be related to lifestyle behavior changes to help you be healthier, stop smoking and vaping, routinely exercise, limit alcohol use, perhaps get into a weight management program. I have had 2 patients that have chosen to add a goal of getting a husbandectomy, which I hoped I had nothing to do with. And both of them did fulfill those life goals. I thought, oh my God. What is your new normal like? You may be told, go find your new normal. Just don't accept or adjust to your new normal. Let's create and design your new normal so it's something you're going to want, not something that you're going to have to put up with. What needs to happen? We need to improve communication with you and your treatment team, PCP education, and having PCP be part of your treatment team. Establish expectations at time of that first consultation regarding how long we would be following you post-treatment and by whom. Patient advocacy and navigation is something you should expect from us. Research and proactive steps to prevent side effects. Research to further improve treatment options. Cancer rehabilitation, if that fits for you. And knowing your milestones and life goals and incorporating and preserving them during and after your treatment. The cancer care domain, that share care model that I mentioned, short and midterm surveillance, acute and short-term complications, and screening you for your secondary cancers that can happen, and as has happened to me. Your primary care domain, that primary care doc, preventative services for diabetes, heart disease, osteoporosis, making sure you get all of your vaccinations, screening for secondary cancers, long-term surveillance if necessary, and long-term complications if applicable. What about those with advanced cancer diagnoses, however? Achieving the 9 elements that are needed to experience a good and peaceful death. Don't postpone joy. If you don't remember anything else I say today, remember that. I don't care what stage you have, don't postpone joy. We don't know what tomorrow holds. You could be hit by a truck. Don't postpone joy. Treatment for treatment's sake is bad care. Decide what criteria you want to use to determine when you want to regain control of your life and call the shots and how you want to spend the remainder of your life, which will be hospice at home. And preserve your milestones and develop alternative ways to fulfill those life goals. You may want to have a card for your daughter who's 10 years old right now, and you're dealing with stage 4 bladder cancer. You may not be here to see her walk down the aisle when she gets married, but you can have a wedding card for her and you can write in it, what do you want to tell her on that day? What do you want to say? you'll be right there along her side. And believe me, when she opens that card and reads it when she's 25 years old, she will feel your presence. I do metastatic breast cancer couples retreats and also retreats for women not in a relationship, so they bring their female caregiver. I do card drives, so we have hundreds and hundreds of cards for these patients to select that day. I have the privilege of hearing from their young children when they become adults and tell me, I felt my mother's presence at my wedding. I felt my mother's presence in the delivery room when I had my baby. Thank you for figuring out a way that my mom could still be here with me. The goal is no longer just to treat the disease and have you be thankful that you're a survivor. The goal is having you come out on the back end of treatment alive and with good quality of life, still on track for achieving your personal life goals. And for those with advanced disease, preserving milestones, fulfilling life goals in alternative ways, and having those 9 elements achieved and not ever postponing joy. I'm now going to quickly tell you a story about my husband. So this is obviously a very personal story. My husband and I were going to be getting a new primary care physician because our primary care physician burned out and left his practice. And we loved him, and he was always there for us. And when he contacted us and said, I'm getting out of medicine, I cried. It was awful. My husband said, I feel so close to him. I could tell him anything. We exchanged dirty jokes when we were in the room by ourselves. And I said, well, I'm going to see who he recommends for us. And he let me know who he recommended. And he said, this is also someone who's takes care of a lot of cancer survivors. And I said, okay. I said, well, my husband's had cancer twice and I've had cancer 3 times. So I was like, this would be a good fit for us. So I went first. She spent an hour with me. She covered everything, met all of my expectations. I really thought she was wonderful. I went home, told my husband about her. I then made him an appointment. And this was 10 years ago, by the way. And so I found out that he canceled the appointment. And I said, what's the problem? I didn't feel well that day. Well, that's when you should have seen her then. No. I made another appointment, canceled that second appointment. I said, wait a minute. What's the problem here? He said, I don't want to see her because she's a girl. He said, we've always had a man. I don't want her looking at me, but most particularly, I don't want her sticking her finger up my butt. And I said, I want her to stick her finger up your butt. I said, and her fingers are probably smaller than our previous male doctors. He said, it's not the size of her finger. It's just picturing her sticking her finger up my butt. I don't want her to do that. I said, sweetheart, my father is right now in hospice at home dying of prostate cancer. Prostate cancer is on my mind. I want to know if your prostate is okay. So I want her to stick her finger up your butt. I'm going to go with you. I'm going to make another appointment. I'm going to take off the afternoon. I'm going to go with you. He fussed the whole way driving there. I wish they had picked a male doctor for me. I don't even know if I would have let a male doctor stick his finger up my butt, but I sure know that I don't want some girl. She could be our daughter. I said, it's true. She's around the age of her daughter. I agree with that. But she's who is chosen for us. I've already had my consult with her. I think you're really going to like her. Oh, he just had a fit. He was not the type to ever fuss. We got there. We got in the room. She's going over it. He had lots of comorbidities to cover. And going over everything. And she got done. And she was with us for an hour and a half. I was very impressed by that. And she said, Mr. Shockney, you can now get dressed. I'm going to step out. I'll come back in a few minutes to review my findings and discuss a plan. And he went, okay. And I said, wait a minute. And he looked at me, he said, be quiet. And I said, no, I'm not going to be quiet. You haven't done a digital exam to check his prostate. She said, no, I won't be doing that today. And he said, you're not going to stick your finger up my butt? And she said, no, sir, I'm not. He said, well, if I had known that, I wouldn't have canceled my other 2 appointments. And frankly, I would have given you 2 co-payments today. And I said, oh, you're going to do a PSA blood test instead? No, I'm not doing that today either. I said, wait a minute. I I don't understand this. She said, I'll explain this to you when after your husband's dressed and I come back in. And I'm like, I don't understand this. I don't understand this. He's dressed. She comes back in, she sits down, and she says, well, here are my findings. She said, your diabetes needs to get a little better control. So I'm going to increase the amount of your this particular medicine. I'm going to add this second drug, which I think will do a better job of keeping your A1C more a level of a score. Um, you have had a heart attack, and I see that you're on 3 medications for that. I want to get some new tests looking at your heart because I can tell you've got an abnormal rhythm now that wasn't noticed last year or the year before, so that could be new. We need to see what that's telling us. And then she talked about his Lyme disease. He has moderate dementia. Um, Cerebral vascular disease, but also peripheral vascular disease and some other comorbidities. And so she went through each one of these. And so I said, now explain why you're not checking his prostate. And she says, Lillie, I just went through all of these comorbidities. It's one of those that's going to take him away from you. If he had prostate cancer right now, we would not be treating it. And I went, oh my God. And then I thought, of course, the Hippocratic Oath, do no harm. Yes, you're right. He just sat there smiling, having no clue what she had said. We get in the car. He says, I really like her. Yeah, she didn't stick her finger up your butt. No, he said, she was great. She covered everything. And I said, you explain to me why she didn't stick her finger up your butt. And he said, because she could tell by looking at my face that my prostate was fine. And I've just let that go. I've let it go. He's had cancer 2 more times. November 4th, just a month ago, he had another heart attack. So she's absolutely right that what's going to take him away from me is not going to be prostate cancer. It'll be something else. And that is important that we do no harm. We should never do treatment for treatment's sake. We need to really assess what's going on with your entire body. Who are you? How do you want to have the rest of your life be? And always, always, always have you participate in shared decision making with us. I'll now open it up for questions.
Well, thank you, Lillie. That was, oh, I was laughing my head off, but you're not going to have a husbandectomy anytime soon, I don't think.
No, no, not at all. Not at
This was
all.
really stunning. And, the whole point of, well, first of all, thank you for coming back and
Mm,
illuminating our world. What we hope to accomplish here is to give patients, in some respects, permission to ask questions and be their best advocates. Um, I do have a comment. When you have the right team and it's the magical team that you miss after cancer goes away and you get very close to people, um, your nurse navigator or your patient navigator is often that one person who you just revere and will never forget for the rest of your life. Many people don't have that. And particular with bladder cancer, and David, help me out here. Bladder cancer, not to knock urology, but it starts in urology and it stays in urology for a long time. So you may not have the benefit of saying have an oncology navigator or even
mhm,
a urology navigator.
mhm.
And in this strained, stressed out world of healthcare, you may have, 15 minutes to sort of uh, get close to your team and share these incredibly important uh, questions that people have, or it's really more the cloud over your head, like in the Peanuts cartoons, of
Yes.
what you really are thinking, or it's blah blah blah, or you're just go totally blank.
Yeah.
So my question to you is, if you don't have the benefit, sadly, of Lillie Shockney, and you don't have the benefit of really super trained nurse navigators who are super skilled at teasing out important information and helping the patients on their journey. It kind of falls to the patient themselves and their caregiver to sort of advocate for themselves. And I have a sort of a statement and a question. How much can you, we want patients to ask these questions,
Yes.
to leave saying, oh, I think I know what's going on, or at least the caregiver wrote it down and says, oh, I think I understand what they said and what this treatment is and all that. How in a 15-minute, slice of stressed out medicine, how is it okay for patients to just say, absolutely, I'm going for it. I want you to know who I am, and this is what matters to me. Hearing it from you, I think, will resonate more than hearing it from me. But
yes, I
more
think
like the patient
I
has
think
to
it's
be a proactive one.
yes, I think it's one of the most important things that has to be discussed and shared during that 15 or 20 minutes. I also think that, a patient may be not an assertive person in general. So whoever becomes their family caregiver does need to be an assertive and sometimes aggressive person. One or the other needs to say, okay, I am your advocate, and we are going to get these things answered. Something that is very common for any physician to do, and unfortunately they're taught in medical school this way. They'll say, okay, here's the treatment plan that I recommend, blah, 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 blah. You understood that, right? And the patient will just nod their head when they have no idea what just got said. Better to say, repeat back to me in your terms what I just said to you. And that's what we find out, wow, we're not on the same page at all. Another option for people is to develop a bladder cancer survivor volunteer team. I have 22 breast cancer survivor volunteers, stage 0 to 4. I've lost 13 to stage 4 metastatic disease. I formed the team in 1997. One of my original 5 is still on that team and leads that team. They can be really, really helpful because they walk the walk and talk the talk. And you can train them up, right, to be the advocate in the room and say, let's ask about thus and so now. Mm-hmm. Or do you want me to ask on your behalf, thus and so? The physicians trust those survivor volunteers because they're people that they took care of. And I asked the physicians, write down the names of people that you'd say, I would love that person to talk to one of my newly diagnosed patients. It's very therapeutic for people that have not just done well from a clinical perspective, but psychologically did well and got the care that they needed. So that could be an alternative. I'll also tell you, which you may not, I wouldn't expect you to know, but a year and a half ago, I created an organization for, it's called the Association for Chronic and Complex Care Nurse Navigators. Oh, so, wow. Yeah, so now there's navigators popping up all over the place that specialize in cardiac disease, in Lyme disease. So we're not just keeping it within oncology anymore, which is good. The other thing that has happened was that in March, 9 months ago, I worked on this for 9 years, and I am not the type to say, okay, it's not going to happen. I'm going to say, damn it, it better happen. Is kind of my approach. That I kept beating on the government, saying, you should be paying for navigation. Huh. This should be a billable service. And it is now, as of March 2024, it is a billable service.
Wow. So
you can actually hire a nurse navigator, and in urology, and Profi Bill. And
Okay, we're
she
on
doesn't
that
have to
one.
be a nurse practitioner. She doesn't even have to be a nurse. She could be a layperson who's been trained and still generate a Profi Bill with a physician. So we are
Amazing.
no longer limited by I was hellbound on that. I thought I know the benefits of all of this, and maybe I need somebody in the government to get cancer. I don't know what I need, but I need something. And finally, every year, beat on this, and they said, "Oh yeah, now we get it. Okay, good."
Well, thank you for doing that. You know, most of, not all bladder cancer care is at Hopkins, where I would, of course, I'm biased where it's somewhat sophisticated because that's all they do. This is what they do all day long,
Right.
when Bladder Cancer Institute,
Exactly.
to Brady and to Kimmel. But those who are not have the benefit, they're in a urology office in somewhere, which is fine, but don't have these really exquisite resources. So what we're trying to do is not only give permission, but empower patients to really remember or give them tools to remember to ask the right questions that are right for them. Because bladder cancer care, as David and everyone will attest, is lengthy, it's complicated, it's the most expensive cancer to care as far as we know. There's frequent visits, tons of follow-up. It lasts a long, long time. It's a very long and tortured journey. Where yes, there can be moments of joy along the way and normalcy, and then there's recurrence, and then there's drama, and oh boy, it's like being on a ship at sea. But so we created this bladder cancer checklist, which is something that we've just been putting together.
Yes.
Resource tool for patients who don't have the benefit of having like Lillie, the fairy godmother, with them in the same appointment room. And so we're posting that on our website and going to send it out across, to anyone. It's available to anyone. It just has like the nifty diagrams because most people don't, like me,
Sure.
know what a
Yeah.
bladder
What's a bladder look like, and where is it?
exactly.
Yeah.
Where.
I'll tell you, my husband said to me, "Who put my prostate up my rear end?" And I said, "God." And he
Yeah,
said, "Oh, I can't argue with him."
yeah. Other things are, you mentioned to have a resource in, luckily for when you're undergoing a fairly significant surgery called a radical cystectomy. I hope people don't have to have that, but when they do, there is, within the surgery team, they do have referrals to patient survivors that
Okay.
can tell their story
I
and
can
share.
say this is what it was like and what to
And
expect. And
yeah, and then we always direct people to the Bladder Cancer Advocacy Network because they have very trained patient advocates, huge,
yes.
and can answer. We're somewhat small players, but we try our best to impart the best information, such as you've given us today, and also empower patients to just be their best advocates, ask questions, ask about things that are really important to them that maybe like would, never even, no one would ever think of. Last month, we had a presentation on uh, bone loss,
Mm,
fragile bones and urinary diversions, which are related. Of course, no one's ever thought of that. We kind of put the pieces together like, wow,
yeah.
beauty and joy is bladder cancer patients are living longer and surviving longer. And all we want is them to survive and thrive and have happy lives and get over
Yes.
the humps of treatment. So we created this checklist for what it's worth. Anyone's available. But you are the queen, Lillie, of early on paving the way for us to advocate for ourselves. I think naturally we don't think we should do that. You don't want to take up too much time. The appointments are very short. There's a lot going on. But I think also physicians appreciate a well-informed patient who can sort of share who they are as
Yes.
a person, who they're going to be
Yes.
sharing this
It's the
journey.
only way we can give patient-centered care is to know that person.
Yeah.
If I'm in a breast tumor board meeting, and some poor resident who's brand new stands up and says, "Today we saw a 54-year-old white female who presented herself with a 3 centimeter," and he gets up and I clear my throat and he stops. And he looks at me. And then he continues on, and I clear my throat louder.
Oh boy.
And he stops and he looks at me, and I will say, "Who is this person? I don't want to know her name, but I want to know who she is. Who is she?" And he said, "Well, I said she's a 50." I said, "No, that is not who she is. That's her pathology.
Right.
Who is she? Tell me who she is. Is she a school teacher? Does she have a 9-year-old with autism? Is she in the process of getting a divorce from her husband? And now she's got breast cancer? I want to know who she is." And I said, "So you have to sit down until you can tell us who she is." And they never make that mistake again. But we always have to go beyond the diagnoses. We are so much more than that. One of the things that came in the chat box wanted to know how to get my slides, and I
Can we share them,
perfectly
Lily?
fine. Absolutely,
So
absolutely.
whoever asked that question, just email bladdercancer@jhmi.edu, and we have them, and we will send them to you. It's a
Absolutely.
PowerPoint. Lily,
Mhm.
you're just a breath, so refreshing, and just calm us down from like the heights of hysteria and difficulty. We want to be here for patients from start to finish and beyond. We love the day
Yes.
when you don't even have to worry that, oh, bladder cancer was so 20 years ago and they're thriving, although it's always a life altering situation, any
Mhm.
cancer. And we want to treat the whole person. We want to be there for them, and we want to help them in the journey, just, with a little cheat sheet on how to present important questions that mean a lot. If the questions don't get answered, that's what I worry about. And also, we are going to now mint t-shirts that say, "You are not your pathology." So we're going to go in the merchandising business.
Absolutely.
Yeah.
It's a powerful statement. I mean, think about that.
You are
Um,
pathology. Lily,
yeah,
thank you so much. Blessings and well wishes to your darling husband. He's like a pincushion of medical challenges, but we love him.
he
And
he
he's
is a
lucky to have
giant
you.
comorbidity, and he's had cancer 2 more times in the last 10 years too. I'm like,
Okay,
good
enough,
grief.
God. Enough. Lay off the guy. He needs a break. Thank you so much. Happy holidays to
Thank
everyone.
you.
We have a new slate. First of all, the bladder cancer checklist will appear on our website within days. It's all completed. And then we have a new series, a 9 grand round sessions starting in January. We're just perfecting the time schedule now. Some really fascinating things, a little off the beaten path. Inflammation and cancer, sleep and cancer. Guess this one, my favorite, comparative oncology. Bladder cancer in dogs. There is such a thing, in what they're doing and what they're learning about bladder cancer in dogs and bladder cancer in humans. Really
How
fascinating,
about that?
cool stuff, and some really
Huh,
important neuropathy. We have a neurologist coming to talk about neuropathy.
good,
Sucks for everybody, right? So
good.
we want to have valuable programming. Information is power. Questions are power. Lily is power. So happy holidays, everybody. And
You're
thank you
both
once
very
again,
powerful.
Lily.
Thank you both so much.
Yeah, you're awesome. Thanks,
Yeah,
everybody.
Yes.
super.
Happy
All right.
holidays and a good new year.
You and a healthy one. Thank you.
Absolutely.
Thank you.